When you're stimulating for IVF, you must decide what is a starting dose of the gonadotropin, whether it is HMG, recombinant FSH, pure FSH. But the starting dose of the gonadotropin is very important, because if you start with the higher dose than required, you may end up with the recruitment of the resistant follicle, uh, the bearing bad oocytes, or maybe ovarian hyperstimulation syndrome unnecessarily, which really you want to avoid. If you give lesser dose than the optimum dose of gonadotropin, then there may be a suboptimal response. So, which also you do not want. The ideal in desirable yield of the oocyte should be somewhere between 8 to 15. If you are getting more than that, it is also not desirable. Less than that, it is also not desirable. I'm talking about especially in normal responder. So, after experience and after uh, reading research papers, we have designed a certain way of deciding starting dose. Like basically consider a standard dose as a 150 international unit. If the age is more than 37, add 75. So make it 225. Suppose patient has got PCOS, then you have to reduce 50 to 75 international unit from the calculated dose. If the patient is obese, the BMI is more than 27, add 75 into calculated doses. If the patient is thin, lean, and BMI is less than 20, you have to minus 75 from the calculated doses. If the patient has got history of ovarian hyperstimulation syndrome before, then even after the standard dose, you have to reduce 75 from the calculated dose. If there is a previous poor response, we have discussed before what comprises of poor response in the previous clips. So if there is a previous poor response, you have to add 75, but the maximum upper limit is 450 international unit. If there is endometriosis or pelvic adhesions or fibroid like other peritoneal disorder, you add 75 into calculated dose. If you have some doubt, the step down is always preferable, except PCOS, where the lowest titrated dose to be started to be continued for maybe 7 days, and then you have to increment slow by slow, which will give you a better result. Now about the antagonist administration. When you will start antagonist? So there are two protocols. One is fixed protocol, another is flexible protocol. In fixed protocol, irrespective of the leading follicle size, the antagonist is started on the stimulation day 5. The advantage of fixed protocol is it takes care of hormonal abnormality and abolishes the chances of LS surge very precisely. But the disadvantage is it increases the gonadotropin consumption and cycle is bit prolonged. The another protocol is flexible protocol. In flexible protocol, when the lead follicle is more than 12 millimeter or E2 level is more than 300 picogram or the stimulation day 7, whichever comes earlier, the antagonist is started. Now there are few studies are coming up and they have shown that if you start antagonist little late, if the follicle, if the E2 is not reach 300 to 400 picogram, there is no disadvantage and it doesn't harm your cycle. But still, I follow a flexible protocol. Any of these three criteria, whenever is met earlier, I start antagonist. Commonly, we use cetrorelix 0.25 milligram subcutaneous to be repeated daily, same time. The delayed administration, earlier paper, they have shown that it reduces the pregnancy rate, but minimal delay doesn't cause any problem. And as we discussed, the early administration increases the gonadotropin requirement. More than 27% from general IVF population who are treated with the flexible GnRH antagonist protocol reach the criteria for antagonist administration later than stimulation day 6. The flexible regime begin antagonist administration later than stimulation day 6. Despite the different stimulation and laboratory characteristic, their reproductive outcome is not compromised as compared to the patients with the earlier antagonist administration. Now coming to a long protocol. Let us discuss what are the benefits of long protocol. I am a strong believer of long protocol. There are hardly any paper which proves the superiority of the antagonist protocol distinctly over long protocol. So I believe in long protocol by default. The benefits of the long protocol: it down regulates elevated LH in the early follicular phase. It ensures proper estrogenic and non-hyperandrogenic environment in the ovary. So the ovary, pituitary, everything is absolutely in quiescent phase, and we are able to manipulate in a way we want. It takes care of early follicular raised progesterone level also. Besides that, the long protocol agonist long down regulation prevents late luteal rise of FSH, thereby preventing asynchronous folliculogenesis and which is especially very important in diminished ovarian reserve. It prevents unscheduled LS surge. It prevents premature utilization of the mature granulosa cells. The another advantage of long protocol, the costing and plan OPU is very much possible. If you do costing for a reasonable period, maybe 2 to 3 days, especially when you are suspecting hyperstimulation or hyper response, it doesn't compromise the results, which is not true with the antagonist protocol. With long protocol, the batching is very easier. Once the patient is down regulated, and even if you want to merge that particular patient with another group of patient, you can continue down regulation agonist, maybe in little reduced dose for furthermore couple of days without any damage. Agonist has got possibly direct positive effect on oocytes, which we'll be discussing in some other talk. Asynchronous follicular growth relatively easy, even if by chance it happens. With agonist protocol, it is relatively easy to manage through the modification of the protocol. This also we'll be discussing in some other talk. The cancellation rate is minimum in long protocol. The peak E2 and endometrial thickness is better. So whenever in the previous cycle with the antagonist protocol, if the peak E2 was less and endometrial thickness was also less, the number of the oocytes were less than expected, we have to switch over to long protocol next time. Another advantage, especially in FET, due to extended down regulation even after stopping agonist. Down regulation, pituitary takes minimum 9 days and maximum recovery takes 6 weeks after stopping the agonist. So, FET in subsequent cycle easily possible without fear of premature luteinization. Now people are talking about disadvantage of long protocol in poor responder, but the study has proved that in poor responder, no statistical difference in pregnancy rate between antagonist and agonist. So poor responder with thin endometrium, low E2, less oocytes are ideal for agonist protocol. In PCOS case, the long agonist works better, especially, sorry, I'm talking about non-PCOS. There are certain non-PCOS cases where AMH is high. So long agonist works better when AMH more than 5 in non-PCOS. So these were the advantages of long protocol briefly. Now there are certain drawbacks also of long protocol. So what are those drawbacks of long protocol? The long protocol means prolonged treatment with more number of injections, because down regulation injection starts from the previous month. Because of the prolonged down regulation, sometimes patient suffers hypoestrogenic symptoms, bony pain, depression, hot flushes, and all those. So, patient may require additive treatment for that. The overall gonadotropin consumption is a little higher side as compared to the antagonist protocol. It causes oversuppression of the ovaries already having diminished ovarian reserve if this protocol is used without modification. This modification we will discuss in some other talk. The agonist trigger cannot be used. This is the biggest disadvantage of long protocol because agonist trigger has changed the life. It improves the oocyte quality, oocyte yield, the maturity of the oocytes, plus it helps in preventing OHS tremendously in antagonist cycle. So the advantage of this master drug as a trigger we cannot have in long protocol. Long protocol is relatively more vulnerable for OHS provided you have not titrated the gonadotropin dose properly. Another disadvantage, back-to-back stimulation of same patient not advisable in long protocol, whereas in antagonist protocol it is possible. The rescue of corpus luteal cyst, especially in diminished ovarian reserve, causing progesterone elevation early before starting of the stimulation, questionably, possibly decreases the result, especially in fresh transfer. Now, let us discuss the advantages of antagonist protocol. The antagonist causes immediate suppression of LH within 8 hours of starting antagonist. There is no induction of hyperandrogenic environment or cyst formation because there is no flare action. There are no hot flush sometimes observed with agonist due to profound transient hypoestrogenism. There are less number of injections, less gonadotropin use, the treatment duration is short, and obviously it is less expensive. But the most important advantage is less risk of ovarian hyperstimulation syndrome. Virtually, you can make your center OHS free if you are using antagonist protocol with the agonist trigger, and freeze all if it is required. The agonist or dual trigger possible with all its advantages. So these are the last two are chief advantages of antagonist protocol. One is reduces the OHS, and second, the agonist and dual trigger possible with all its advantages. But there is a long list of drawbacks of antagonist protocol. So let us look into it. The antagonist hampers the endometrial receptivity by direct action on it. There are some studies which concluded the antagonist has got anti-mitotic action, so it reduces the cell division. Now, at what level this can be detrimental, still more studies are required. The antagonist protocol, the asymmetrical follicular profile is very much common and troublesome. There are unrecognized raised LH, androgens, progesterone, estrogen in early follicular phase can disturb oocyte quality and growth. There are a lot many studies they have said results are inferior in normal responder, probably because of too much suppression of LH in mid and late follicular phase. The batching is really difficult compared to the long protocol. The perfect judgment to start antagonist is required, as delay may cause premature LS rise and early start may prolong the stimulation with higher consumption of injection. The overall number of the oocyte retrieved are less in antagonist protocol. The people are using OCP pretreatment. The OCP pretreatment requires longer stimulation, higher total gonadotropin dose, increases the early pregnancy loss due to low LH at the beginning, affecting the oocyte quality. But one good thing, the recent study found that it is not as detrimental as which was thought previously. Costing big no. Costing results in higher incidence of endometrial advancement in antagonist cycle. There are varied proportion 0.34 to 38% of the patient using antagonist protocol experience premature LH surge. Especially, this is true with the older patient and patients with diminished ovarian reserve. The early follicular progesterone elevation chances are 5 to 13%, unlike the long agonist protocol. In PCOS, the tonically elevated LH till you start antagonist may be detrimental to a growing follicle. On a side note, the GnRH antagonist protocol showed added risk of major congenital malformation such as Beckwith-Wiedemann syndrome and minor malformation such as Neves-Keintax, torticollis, pyloric stenosis, and asymmetrical head shape. So these were the drawbacks of antagonist protocol. Next time we will discuss other protocols. Thank you.